Okay, guys. This is the Chapter 17 podcast over reproductive system diseases and disorders. And so, what we're going to do is review some of the normal functioning of the reproductive system, and then we'll discuss some of the diseases that can affect it. Now, if we look here at the female reproductive system, what we see is a system that's set up generally to house another human being as it develops for 9 months inside the womb. This system produces and delivers gametes. Now, the female gamete is the egg, the male gamete, of course, is the sperm. It also provides nutrition and room for fetal development. It gives birth and it nourishes the infant. And you can see a lot of the structures here. Notice some of the key structures. Let's start at the top and work down. Here you can see the paired ovaries. They're on the lateral body wall inside the abdominal pelvic cavity of the female. This tube that connects the ovary to the uterus is called the fallopian or uterine tube, and it leads directly into the uterus at the anterior or superior aspect known as the fundus, this little domed upper portion. It's important to note that the fallopian tube and the ovary are not a fused structure. As a result, occasionally when an egg is ovulated, sometimes it can enter the abdominal pelvic cavity, and if fertilized, it can implant inside the body wall, and this is known as an ectopic pregnancy, and generally this is an emergency situation for both mother and child. Often this ends in a surgical abortion, but occasionally these ectopic implants can be rescued, reimplanted in the uterus, and allowed to develop fully. The uterus is the area where the baby develops over the course of its 9 months, divided into 3 trimesters. It has several layers. It has an outer adventitia, it has an inner myometrium, and it has an inner endometrium. And it's the endometrial lining that is shed monthly during menses in a cycle that repeats until the last egg is ovulated from the ovary, and that represents the condition known as menopause. This is the rectouterine pouch, this area between the uterus and the rectum. And over here is the vesicouterine pouch. The significance of these two open areas is sometimes they can house extant endometrial tissue, a condition known as endometriosis, in which the endometrium, which is normally confined to the uterus, can actually begin to grow inside the abdominal pelvic cavity and cycle with the menses. And down here is the bladder. This is the urethra. This is the vagina. This is the cervix. This is the external opening of the uterus. This is the internal opening. And this, of course, is the rectum and the anus. These large folds here, this is the labia majora, the labia minora. This is the pubic symphysis. This is the joint that becomes more flexible during delivery for the passage of the baby, which normally exits the birth canal head first. And I believe that brings us to the end of the most important structures. Maybe a couple other things. The fimbriae that are at the lateral edge of the fallopian tubes, little finger-like structures, these brush the ovary, and when there is a mature follicle, what happens is that the follicle, as a result of its development, has become fragile, and it's actually the brushing of these fimbriae against these mature follicles inside which the egg sits in the ovary that allows it to rupture and then be sucked into the fallopian tube on its journey eventually to the uterus. Okay, here's a little bit on the female reproductive system.
The major structures of the female reproductive system are the 2 ovaries, 2 fallopian tubes, the uterus, and the vagina. A normal female is capable of reproducing from the onset of menstruation during puberty until the end of menopause. The female is fertile and able to become pregnant approximately during the 13th and 14th days of each menstrual cycle. The total number of eggs a woman will produce in her lifetime are present in her ovaries when she is born. Each month at the beginning of a menstrual cycle, the pituitary gland secretes the follicle-stimulating hormone, which is commonly known as FSH. This hormone stimulates one egg to mature with an ovary. The maturing egg is surrounded by a Graafian follicle. On the 13th or 14th day of the menstrual cycle, the Graafian follicle ruptures and releases the mature egg from the ovary. Because the fallopian tube is not attached to the ovary, the finger-like fimbriae must catch the egg and guide it into the fallopian tube. After the release of the egg, the Graafian follicle changes and becomes the corpus luteum, which secretes the hormone progesterone in preparation of the lining of the uterus to support a pregnancy. If the egg is not fertilized, the corpus luteum dies and the progesterone secretion ceases. The menstrual cycle is then completed with a menstrual period. If the egg is fertilized as it travels down the fallopian tube, the corpus luteum continues to produce progesterone. The fertilized egg moves into the uterus where it is implanted. The placenta forms, and, for the duration of the pregnancy, it secretes the progesterone required to maintain the pregnancy. Throughout the 40 weeks of the pregnancy, necessary nutrients are supplied and waste products are removed by the placenta and the umbilical cord. When it is time for the baby to be born, the pituitary gland secretes the hormone oxytocin. This hormone stimulates the labor contractions that result in the birth of the child. After the infant has been delivered, the final stage is the delivery of the placenta as the afterbirth.
Okay, the male reproductive system is a little bit different. The male, unlike the female, is fertile from puberty until death. The female is fertile from menarche to menopause. The male gametes are known as the testes, and they hang outside the abdominal pelvic cavity in a sac called the scrotum. The sperm are actually generated inside this organ. This organ also produces testosterone. The epididymis is the area where the sperm learn to swim, to learn to use their flagella. And then this tube is the vas deferens. The vas deferens joins with the urethra at the ejaculatory duct. This is the area right down here, okay? And then the urethra in the male has actually three regions. There's the prostatic urethra that runs through the prostate gland, shown here, the membranous urethra, and then the penile urethra that runs through the shaft of the penis. As a result of this increased length of the urethra, men are less likely to get UTIs than women are. This is the glands of the penis. This is the corpora cavernosa. Enclosing the urethra is the corpus spongiosum. This is the bulb of the penis. The glands that contribute to the semen include the testes, the bulbourethral gland, the seminal vesicle down here, and the prostate gland. All of these combine to form semen, which exits the penis during ejaculation. The rectum and the anus, shown here, are extremely close to the prostate gland. As a result, when a man is examined for the possibility of prostate cancer or prostatitis, the way this is done traditionally is through a digital rectal exam, palpating the prostate through the wall of the rectum in order to test for any enlargement. If the prostate were to enlarge, what would happen is it could occlude the urethra and block the flow of urine from the bladder to the outside world, and this would of course constitute a medical emergency because of the pressure that would eventually build up, move through the ureters to the kidney, and could potentially result in kidney failure. Okay, I believe, the pubic symphysis again here, and the prepuce, also known as the foreskin, is commonly resected in a procedure called a circumcision, and this is usually done for hygienic reasons in order to cut down on bacterial growth between the prepuce and the glands. Common practice in the United States. Okay, common signs and symptoms of reproductive diseases in the female include abdominal and pelvic pain, fever and malaise, abnormal vaginal discharge, burning and itching of the genitals, and pain during intercourse. Also, any change in breast tissue or abnormal discharge from the nipple. For the male, we see urinary disorders such as increases or decreases in frequency, dysuria, nocturia, which is urination at night, and incontinence, which is an inability to hold the urine. Also, pain in the pelvis, groin, or reproductive organs can be indications of disease, as are lesions on the genitals. So let's take a look at the male reproductive system.
The primary role of the male reproductive system is to produce and deliver sperm to fertilize an egg in the female. These sperm are produced outside of the body cavity by the testicles, which are located in the scrotum. The scrotum protects and supports the male reproductive organs that are located outside of the body cavity. These include the testicles, epididymis, and vas deferens. The testicles produce about 300 million sperm each day. However, this is possible only if the temperature of the testicle is 93.2 degrees Fahrenheit. The scrotum maintains this temperature by adjusting how closely it holds the testicles to the body. The interior of each testicle consists of multiple lobules, containing 2 or 3 seminiferous tubules. It is within these tubules that sperm formation begins. The sperm moves out of the tubules into the epididymis, and then into the vas deferens. The vas deferens carry the sperm upward into the body cavity. After the sperm leaves the vas deferens through the ejaculatory ducts, they pass the openings of the seminal vesicles. The seminal vesicles, which are located near the base of the ejaculatory ducts, secrete a thick yellow substance to nourish the sperm. This secretion forms 60% of the volume of the semen. Semen is the sperm-containing fluid that is ejaculated at the climax of male sexual excitement. From here, the semen travels into the 8-inch long urethra, which transports both urine and semen, but not at the same time. At first, the urethra is surrounded by the prostate gland, and then it is surrounded and protected externally by the penis that is relaxed except during sexual excitement. During sexual excitement, the penis stiffens and enlarges so it can deliver the sperm into the female vagina. During the expelling of the semen, which is known as ejaculation, the prostate gland secretes a thick alkaline fluid that increases the ability of the sperm to move in the semen. Located just below the prostate gland are the bulbourethral glands. These glands open into the urethra, and, during sexual arousal, they secrete the pre-ejaculate fluid that flushes out any residual urine from the urethra. It also lubricates the urethra to help the sperm pass through. When the male ejaculates into the vagina of the female, the sperm must travel upward through the uterus to fertilize the egg in the fallopian tube.
Okay. Common signs and symptoms for males also include swelling or abnormal enlargement of the reproductive organs, abnormal penile discharge, and burning or itching of the genitals. How do we diagnose some of these disorders? Well, we can do a bimanual exam. We can do a hysterosalpinogram. We can do a pap smear or cervical or cone biopsy. We can do dilation and curettage, a laparoscopic exam, a mammography, or we can do blood tests. Now, for those of you who may not know, I mean, some of these are procedures that I'm sure you've heard of before, but bimanual exam may be a new term for a lot of you. This is a pelvic exam where we do a physical exam of the female pelvic regions using palpation. It can be divided into an external and an internal examination. The external examination would be to palpate the cervix, and the internal examination would be, the external examination would be to palpate the uterus. The internal examination would be to palpate the cervix and the vaginal opening for any unusual disease states, growths, wounds, infection. A hysterosalpingogram is an X-ray test that examines the inside of the uterus and the fallopian tubes as well as the surrounding area. Now, cervical biopsy, I'm sure you have some familiarity with. That's simply an actual sampling of the cervical tissue followed by staining and examination under a microscope to look for any changes that could indicate infection or perhaps the development of cancer. But a cone biopsy is a more extensive version of this. It's called a cone biopsy because a cone-shaped wedge of tissue is removed from the cervix and examined under a microscope. And then finally, dilation and curettage is the widening of the cervix and the surgical removal of part of the lining of the uterus and its contents by scraping or scooping. Um, this is sometimes used as a method of surgical abortion. Here's an example of a laparoscopic exam. The laparoscope is inserted through the umbilicus, and we use it to examine now the abdominal pelvic cavity. Very often gas is introduced in order for there to be more space to maneuver the scope around in order to examine the internal contents. You can see any external problems in the ovaries, the fallopian tubes, the outside of the uterus, or the rectouterine or vesicouterine pouches. Digital rectal exam is used for males to palpate prostate. The gloved hand of the researcher is inserted through the anus and the rectum, and the prostate is felt for any unusual growths or any unusual enlargement. The danger here, of course, is not only can this occlude the ureter and as a result block the flow of urine out of the bladder, it can also be an early indication of a cancerous change, prostate cancer being one of the most prevalent cancers in the male population. Biopsy, again, is just a sampling of the tissue. A cystoscopy is examination of the bladder using a cystoscope, and there are also lab tests you can perform, such as the PSA test, which is a blood test to detect a prostate-specific antigen. That's what PSA stands for, as an early indicator of prostate cancer. Again, the key here being the early detection usually leads to more successful treatment. Okay, premenstrual syndrome is a cluster of physical and emotional symptoms that appear shortly after ovulation and subside with the onset of menstruation or shortly thereafter. A woman may notice changes that are related to hormone levels that fluctuate as she prepares for ovulation and pregnancy. What actually happens during ovulation is that the egg erupts from the follicle and normally enters the fallopian tube on its way to the uterus. If fertilization does not occur during ovulation or shortly thereafter, the egg is passed out with the menstrual flow and there is no pregnancy. What are some of the symptoms of premenstrual syndrome? Well, anxiety, anger, sadness, food cravings, fatigue, tenderness in the breast, irritability. Women also experience edema, a swelling basically, sometimes peripheral edema, a bloated feeling, along with abdominal pain. The cause and symptoms appear to be related to fluctuations in the amounts of estrogen and progesterone in the bloodstream. These are female sex hormones, and they control the uterine and the ovarian cycles. When these cyclic symptoms become more severe and fit certain psychological criteria, the diagnosis shifts from PMS to premenstrual dysmorphic disorder, or PMDD. So how do we treat this? Well, there's usually treatments directed towards the relief of the symptoms. We reduce the dietary intake of sodium to reduce the increase in blood pressure and the edema. Moderate exercise is also useful, as are analgesics for pain and diuretics, again to reduce edema and to reduce blood pressure and blood volume. Emotional support is often recommended, and there are also antidepressants and hormone therapies that can target PMDD. It's also recommended that we increase calcium intake to compensate for bone loss, osteoporosis, which can often accompany these fluctuations in estrogen and progesterone. There are no specific tests to diagnose PMS. The symptoms usually subside 2 to 3 hours after the onset of menses. The way that you distinguish PMS from depression is that emotional symptoms may appear shortly after ovulation and subside with the onset of menstruation, or shortly thereafter. Depression doesn't follow this pattern. Depression tends to continue. There are also other menstrual abnormalities that we should be aware of, such as amenorrhea, dysmenorrhea, menorrhagia, and metrorrhagia. So let's discuss what each of these are. So if we break down each of these terms by their definition, amenorrhea is defined as an abnormal absence of menstruation. Dysmenorrhea would be a painful menstruation, typically involving abdominal cramps. Menorrhagia is abnormally heavy bleeding during menstruation, and metorrhagia is abnormal bleeding from the uterus. So let's address our first condition affecting the female reproductive system, and that is endometriosis.
Endometriosis is one of the most common health problems for women the world over, possibly affecting 5 million American women. So what is endometriosis anyway?
Endometriosis occurs when tissue that looks and acts like the lining of the uterus actually grows in other areas of the pelvic region. Because this condition is one of the leading causes of infertility, it helps to be familiar with endometriosis. The tissue that lines the uterus or womb is called the endometrium. Every month, female hormones cause the endometrium of a woman's uterus to build up with tissue and blood in preparation for pregnancy. If pregnancy doesn't occur, the uterus sheds this built-up lining via the vagina as a menstrual period. Although this process occurs in women with endometriosis as well, it's a bit more complicated. That's because women with endometriosis have patches of endometrium that grow outside the uterus, in places like the ovaries, the fallopian tubes, the bowels, or the bladder. This misplaced tissue responds to the monthly cycle just as the endometrium does. Each month, the patches or plaques grow thicker. As the tissues affected don't have a natural exit route, there is no place for the buildup to leave the body at the cycle's end. These endometriotic plaques can grow larger over time and the symptoms can worsen. A symptom suggestive of endometriosis is chronic pelvic pain that tends to be worse during menstruation or ovulation. Other symptoms include very painful or heavy menstrual periods, pain during or after sex, and uncomfortable urination or bowel movements during menstruation. Contrarily, some women have no symptoms at all. Infertility is another sign that can suggest that endometriosis is present. Indeed, some women do not realize they have endometriosis until they attempt to conceive and cannot do so. Endometriosis can lead to infertility because it may cause scarring or blockage of the body's fallopian tubes, which are necessary to transport eggs from the ovaries to be fertilized. Unfortunately, no one has identified endometriosis' exact cause, although a genetic link is often theorized. Regardless of the cause, there is currently no cure for endometriosis. However, medication can help to ease the pain and menstrual symptoms that can accompany the condition. In addition, surgery aimed at removing the buildup may assist women with infertility causing endometriosis, as well as patients with very severe cases. Endometriosis is very common, and the symptoms of the condition are treatable. If you have concerns about endometriosis, please make an appointment to discuss them with your doctor.
Want to learn more? Check out other videos and sources on this site for more information.
Endometriosis involves tissue that normally is found inside the uterus but is now in an ectopic location. It's considered a benign condition but can be painful and chronic. The endometrial tissue was originally located in mucous membranes that line the uterus. Okay, pelvic inflammatory disease is an infection in the woman's pelvis. It is self-limiting to life-threatening, and it can affect all the female reproductive organs. The symptoms include fever, chills, malaise, foul-smelling vaginal discharge, backache, and painful tender abdomen. Those at risk are young, sexually active women, especially those with more than one sex partner. PID is usually started as a sexually transmitted disease, and the pain associated with it may make even walking a difficult task. How do we diagnose this? Well, there's normally tenderness during a vaginal exam. There are signs that include an elevated white count and fever. Ultrasonography can be used to identify abscess formation, and laparoscopy is useful to confirm the diagnosis. A vaginal exam is usually painful because of the swelling and inflammation associated with this condition. General antibiotics fail to work for PID because the infection is often multibacterial, including both anaerobic and aerobic strains. So there are strains that consider oxygen toxic, and there are also strains that grow very, very well in an oxygen-rich environment. As a result, the most effective treatment is going to be probably a whole host of antibiotic treatments as opposed to a single medication. So the treatment is aggressive antibiotic therapy to treat the disease and to help prevent complication, along with analgesics and bed rest. Without effective treatment, serious life-threatening complications develop. Early diagnosis and prompt treatment lessens the damage to the reproductive system, and inflammation can cause scarring and adhesions that can cause infertility and increase the risk of an ectopic pregnancy. Okay, next is ovarian cysts. Let's keep in mind that the ovaries are the female gonads that produce eggs and female hormones, estrogen and progesterone. Most ovarian cysts are physiologic and occur from puberty through menopause. And inflamed cysts can be a result of a sexually transmitted disease or an acute infection. So let's take a listen to ovarian cysts.
Ovarian cysts are a very common female condition. An ovarian cyst is a fluid-filled sac on an ovary in the female reproductive system. Most women have ovarian cysts sometime during their lives. Fortunately, most ovarian cysts are benign and do not need any special treatment. This patient education program will help you understand ovarian cysts and how they may be diagnosed and treated. Anatomy. The female reproductive organs include the vagina, the uterus, the fallopian tubes, the ovaries. The female reproductive organs are located in the pelvis between the urinary bladder and the rectum. The ovaries have two main functions. One, the production of specialized hormones such as estrogen and progesterone. Two, ovulation, which is the release of eggs that are needed for reproduction. The hormones produced by the ovaries are very important in keeping ovulation regular. These hormones also prepare the inner lining of the uterus to proceed with a pregnancy. Before the egg is released, a small cyst forms on the ovary. A cyst is a fluid-filled area. When the egg is released, it goes down to the uterus through the fallopian tube, where it may be fertilized. The cyst on the ovary usually disappears at that time. If the egg is not fertilized, the egg and the inner lining of the uterus are discharged to the outside of the body during the menstrual period. This cycle repeats itself every 28 days while the ovaries are still active. The uterus is pear-shaped. It is about 3 inches long and it has 3 layers. The inner layer of the uterus is called the endometrium. Causes. An ovarian cyst is a fluid-filled tissue sac that appears on the ovary. The sac can be within or on the surface of the ovary. Some cysts fail to release the egg and can grow up to 1 or 2 inches. These cysts are called follicular cysts. They usually disappear in 2 to 3 menstrual cycles. Some cysts are called corpus luteum cysts. These occur after the egg has been released. They can grow up to 4 inches in size. They also usually disappear within a few weeks. Other ovarian cysts are due to benign tumors. A benign tumor is a tumor that does not invade other tissues and is not cancerous. These include dermoid cysts, endometriomas, cystadenomas, polycystic ovaries. Dermoid cysts. The cells in the ovary are able to make hair, teeth, and other growing tissues that become part of a forming ovarian cyst. These cysts can become large and cause pain. Endometriomas. These cysts develop in women who have endometriosis when tissue from the lining of the uterus grows outside of the uterus. The tissue may attach to the ovary and form a growth. These cysts can be painful during sexual intercourse and during menstruation. Cystadenomas. These cysts develop from cells on the outer surface of the ovary. They are often filled with a watery fluid or thick, sticky gel. They can become large and cause pain. Polycystic ovaries. The eggs mature within the follicles or sacs, but the sac doesn't break open to release the egg. The cycle repeats, follicles continue to grow inside the ovary, and cysts form. In this case, increased body hair may be noticed by the patient. Some benign ovarian cysts may increase the risk of ovarian cancer. Malignant tumors, or cancer of the ovaries, can start as a cyst on the ovaries. Symptoms.
Okay, fibroids are the most common tumors in the female reproductive system. They tend to calcify after menopause, and they can occur in about 40% of women after menopause. So let's take a listen to fibroids.
Hello my friends. The topic I'm going to focus in this short video is uterine fibroids, also known as myomas. Fibroids are the most common benign tumors that can affect women. And to understand the variety and intensity of symptoms, it's important to know how these tumors are classified according to their location in the uterine wall. This is a frontal view of the uterus. Here are the outlets of the fallopian tubes, and down here we see the cervix. The external surface of the uterus is covered by a serous membrane, also known as peritoneum, and this soft mucosal lining that we see here in the uterine cavity is the endometrium. Now let's explore the navigation bar and press this first button. What we see. If the tumor grows near the external surface of the uterus, just beneath the serous membrane, we call it a subserous myoma or subserous fibroid. And if the tumor grows towards the cavity of the uterus, protruding the mucosal lining, we call it a submucosal myoma or submucosal fibroid. And finally, if the tumor grows within the muscular wall, we call it intramural fibroid or intramural myoma. There's an observation to be made about tumors that grow near the internal or external surface of the uterus. They may eventually detach from the body of the uterus and get suspended by a peduncle. And when the origin is in the uterine cavity, the peduncle may stretch until the tumor is literally expelled through the cervix towards the vagina, like this. Now let's talk about some symptoms of the woman with uterine fibroids. All of these tumors may cause some degree of abdominal discomfort. In case of a subserous tumor like this one, it's easy to understand that if it grows towards the bladder wall, it can cause urinary symptoms such as pain or increase the frequency of urination and infections. Now, when the tumor progresses towards the cavity of the uterus, it causes a protrusion of the endometrium that can lead to bleeding between periods, cramps, abortion, and even fetal deformities because of the shortage of space within the uterus. Another important consequence is infertility, and it occurs when the tumor grows near the fallopian tube's outlets, here and here, reducing the lumen of the tubes and impeding the passage of both sperm and ovum. And this type of tumor, the pedunculated one, may undergo torsion of the peduncle and cause intense pain and even necrosis due to the subsequent blockage of its blood supply by the twist. So in a few minutes we were able to understand what are uterine fibroids, how they are classified according to their location, and which are the main complications of each one. My name is Evan Prado Jr. and I am a medical doctor and an artist, and this interactive digital animation was made by me. You can find more interesting medical themes like this one in my personal website. I hope I could have helped you to clarify your doubts about this important medical issue on women's health. Thank you very, very much for your attention.
Okay, vaginitis is an inflammation or infection of the vaginal tissues. The fungal infections are the most common cause of vaginitis, but they can also be caused by bacteria or protozoans. Cervical infections can be mistaken for vaginitis as well. Postmenopausal women are at a greater risk. It's common in all age groups. Infection may not cause the symptoms in a male, but if he's carrying it, he can be capable of transmitting it to the female as a result of reinfection during intercourse. Postmenopausal women have less estrogen, and this causes the vaginal lining to be thinner and as a result more susceptible to infection. The symptoms include vaginal discharge, an itching or burning sensation of the vulva, and there may also be fever. Diagnosis is made with a pelvic exam and specimens from the vagina and cervix, and these are analyzed in a lab setting. The treatment is hormone therapy, antibiotic therapy, and vaginal antifungal or steroid creams, or a combination of all three. With proper treatment, the inflammation usually clears up in a week, but it can recur, and it often does in many women. A female may be susceptible to recurring infections due to poor hygiene and unprotected sex. Okay, our next disease is toxic shock syndrome. So let's take a listen to toxic shock syndrome and how it is produced. Keep in mind that one source of this particular condition are superabsorbent tampons that can predispose a woman to this type of an infection.
Hi, I'm Dr. Mika Lane. I'm with Cascadia Women's Clinic in Vancouver, Washington, and I'm an OBGYN. Today I'm going to talk to you about the seriousness of toxic shock syndrome. Toxic shock syndrome is a bacterial infection that can trigger the release of toxins. These toxins, unfortunately, can attack your body and cause a whole host of medical problems or medical issues. Toxic shock syndrome can be extremely serious. Some of the more serious complications that can occur with toxic shock syndrome include pleural effusions, where there is a buildup of fluid in your lungs. Also respiratory failure, which potentially can lead to you having to be placed on a ventilator, which is a mechanical breathing machine. Sometimes toxic shock syndrome can lead to multi-system organ failure, which means that each individual organ system slowly starts to shut down and no longer can support you. And unfortunately, death can occur after this particular process. If you suspect that you have any signs or symptoms of toxic shock syndrome, you need to be talking with your healthcare provider in order to seek health care.
Okay, menopause represents the cessation of menstrual periods. Menstruation discontinues due to the fact that the ovaries are producing less estrogen, and this inhibits ovulation. Changes in pituitary hormone levels also bring about physical and psychological changes. Many women experience the onset of menopause between 45 and 55, but it can also be induced artificially by the removal of both ovaries, and this is termed surgical menopause. What you have to realize is that as eggs are ovulated on a monthly basis, we begin to deplete the number of follicles inside the ovary. The follicles are the structures that are responsible for producing estrogen and progesterone. So when we get to menopause, one of the things that happens is that so much estrogen and progesterone producing capability has left the ovary that it's incapable now of properly regulating the uterine cycle. So the result here with the last egg leaving the ovary is now menopause. There's no longer a need for the uterine cycle because there are no more eggs to implant, and as a result, due to the, again, decline in estrogen and progesterone production, there's no more cycling of the endometrium. The symptoms include fluctuations in the menstrual cycle. The periods become lighter and less frequent and eventually stop. There are also hot flashes and night sweats along with vaginal dryness and skin changes. Some women also experience depression, poor memory, anxiety, and sleep disorders, as well as a loss of interest in sexual intercourse. An accurate diagnosis can be made with blood tests to measure if certain hormones are high and estrogen levels are low. Can menopause be avoided, and if not, why? Well, it can be avoided with new birth control methods that can reduce the frequency of menstruation to once a year. It's theoretically possible to avoid menopause within the normal lifespan. However, this isn't a practical form of physiological, or either from a physiological or a financial standpoint. You may have heard some of these new medications that reduce the number of menstrual periods to a vanishingly small amount, and that would result then in the preservation of more eggs within the ovary, and as a result of dilation of the window for a reproductive age. The treatment consists of management of the symptoms. Recent research, however, links hormone replacement therapy with increased rates of both breast cancer, heart disease, stroke, and blood clots. HRT is used as conventional treatment less and less because, again, of the predisposition to these complicating factors. So it's no longer highly recommended for peri- and postmenopausal women to treat the symptoms of menopause. Osteoporosis is a common concern in menopause, again, due to the reduction in the production of estrogen and progesterone, both of which help maintain bone density. Osteoporosis, again, is a pathological thinning of the bone mass due to decreased osteoblast activity. Alternate symptom management is suggestion. Consumption of soy products can be used to replace missing hormones. These are high in isoflavones, which are precursors to estrogen and progesterone, and there are also medications that strengthen bones, lower cholesterol, and help remove vaginal dryness. Some physicians recommend the use of hormone replacement therapy for severe cases, but for short periods lasting from 2 to 5 years, instead of long-term use as previously described. The prognosis is good since most women experience symptoms for a limited time. Okay, uterine prolapse is where the uterus has a downward displacement from its normal location in the body. It becomes prolapsed when the pelvic floor muscles and ligaments become extremely overstretched or weakened, and it protrudes now from the vaginal orifice. The pelvic floor muscles weaken as a result of childbirth, old age, or genetic factors. The prolapse is usually visible in a pelvic examination. The purpose of the pelvic floor muscles during pregnancy is to increase the tautness of the uterine supporting ligaments. And as they lose their tone, the uterus, as you can see in this photograph, can begin to descend from its normal orientation. As the muscles and ligaments become overstretched, they can't hold the uterus in place, so it falls or sags downward, and this causes a lump or a bulge in the vaginal wall. The prolapse can be so severe that the cervix can bulge out of the vagina, and this is called a complete prolapse. Surgical repair is often indicated for this particular condition. Complete prolapse, partial prolapse, normal position. How do we treat? Well, we can use Kegel exercises to strengthen the pelvic floor muscles. Weight loss and high-fiber diets are also recommended, as well as the insertion of supportive uterine devices, such as a pessary. Surgery can also be used for serious prolapse. A high-fiber diet is prescribed to reduce the amount of straining in the bowels, which can have a negative impact on the position of the uterus. Weight loss can improve a uterine prolapse because it reduces the pressure on the uterus proper. A pessary is a device that's inserted into the vagina in order to support the uterus. The prognosis is generally very good, even if surgery is called for. Okay, a cystocele is a herniation of the urinary bladder through the anterior vaginal wall. Symptoms include an increase in pelvic pressure and an increase in urinary urgency, frequency, and also episodes of incontinence. The treatment depends on the degree of herniation. An erectocele is essentially a protrusion of the rectum through its opening. If childbirth is the cause, it may not become evident until years later. So let's take a listen to rectocele.
There are many different procedures that can be performed for the treatment of a rectocele, which is the bulging of the rectum into the back wall of the vagina. Here at Flora Robotic and Minimally Invasive Urogynecology, we perform everything in minimally invasive fashion, and we tailor a surgery to the individual. Everyone has different physical activity levels, different medical history, and even different amount of sexual activity. We take all these things into account, along with the patient's anesthesia risk, before devising a plan of care. Traditional repairs may be performed, but studies have shown that using grafts has a much better long-term success when it comes to the treatment of a rectocele. A graft can be placed through a very small vaginal incision between the rectum and the vagina, as shown here in white.
Okay, cervical cancer is a condition of high concern among women. The cervix is the lower portion of the uterus, and its function is to allow sperm into the uterine cavity, and it also serves as a birth canal for the child. And it can be affected with a shift from normal tissue function to cancer function, often under the influence of hormone signals or as a result of spontaneous mutation or exposure to carcinogens. So let's take a listen to cervical cancer.
So let's talk a little bit about cervical cancer. So cervical cancer is cancer of specific cells on the cervix known as squamous cells. Now interestingly, cervical cancer is very highly associated with the human papilloma virus, and more specific, even certain strains of the human papilloma virus. Now, what are some of the risk factors for developing cervical cancer? Well, you can imagine that First, early sexual contact would be a risk factor for potentially picking up these associated HPV strains. In addition, multiple sexual partners. So the more sexual partners you have, the greater the risk of picking up a strain of HPV that is associated with cervical cancer. And also venereal warts or genital warts, which are caused by more benign forms of human papillomavirus. So if you have venereal warts, you may also be harboring an HPV strain that could potentially result in cervical cancer. Now, other less common causes of cervical cancer or risk factors for cervical cancer would be family history, puts you at an increased risk, as does smoking. So if you're a smoker, you also have an increased risk of developing cervical cancer. So how do we go about diagnosing cervical cancer? So how do we go about diagnosing cervical cancer? So the first step is usually with a pap smear, and a pap smear is looking for atypical squamous cells of the cervix. Now, ultimately, there are 5 different types of results that we can get from a pap smear. The first result being normal, which is a good thing. The second result being atypical squamous cells of undetermined significance. The third result being atypical squamous cells of high-grade significance. The fourth result being low-grade squamous intraepithelial lesion, and the fifth result being high-grade squamous intraepithelial lesion. Now, any abnormal result is going to go for what is known as HPV reflex testing, and that's basically looking for the human papillomavirus in any abnormal sample that could potentially be a risk factor for development of cervical cancer. Now, certain grades of pap smear, such as the ASCH, low-grade squamous intraepithelial lesion, and high-grade squamous intraepithelial lesion, will go for what is known as colposcopy. And colposcopy is a fancy word for basically direct visualization of the cervix. And what we do is we look for abnormal areas on the cervix and then biopsy those lesions. Now, a biopsy will give us a tissue diagnosis, and the tissue diagnosis follows different grades as well, basically known as cervical intraepithelial neoplasia, or CIN. Now, there are different grades of CIN, being CIN 1, 2, and 3. So CIN 1 is basically a low-grade form of kind of a precancerous lesion. CIN 3 would be a higher grade form of a precancerous lesion, but the important part is that it is still precancerous. Now, occasionally off of colposcopy we can see frank cancer, at which point there would be different treatment algorithms, which is what we'll discuss in the next section. So treatment is really going to depend on the results of the pap smear and potentially the colposcopy with biopsy if you have that done. Now, ultimately, if you have a pap smear that shows ASCUS, or atypical squamous cells of undetermined significance, and the HPV testing comes back as negative, meaning you do not have the HPV viruses associated with cervical cancer, you can go into routine pap smear screening, or basically usually a pap smear every year. Now, if you have atypical squamous cells of undetermined significance with HPV positivity, or atypical squamous cells of high-grade significance, low-grade squamous intraepithelial lesion, or high-grade squamous intraepithelial lesion, all of those are going to go to colposcopy as discussed earlier. Now, if a biopsy is done at colposcopy and you have a cervical intraepithelial neoplasia first grade, or CIN 1, those are going to be routinely followed with a pap smear, usually every 4 to 6 months, until 3 negative pap smears are obtained, at which point you would undergo routine pap smear screening every year. If you have CIN 2 or 3, which is a slightly higher precancerous lesion of the cervix, those will generally undergo what's known as ablation therapy, perhaps the most common type being the LEEP procedure, the LEEP, which stands for Loop Electrosurgical Excision Therapy, and ultimately results when they take a very small rind of the cervix out to remove that precancerous lesion. Now, if the colposcopy biopsy results come back as cancer, now we're talking about an entirely different treatment algorithm that's going to depend on the stage of the cancer, and if there's been any distant spread into the pelvic area. and ultimately the treatment can become very complicated depending on what grade you have. So I hope this has given you at least a brief introduction to cervical cancer and how we detect it and screen for it. And check out the website for a little bit more detailed discussion on this disease. Thank you.
Okay, uterine cancer develops in the endometrium and it spreads to the uterine wall. The symptoms include abnormal bleeding in menopausal females, and the treatments include surgical removal of the uterus and ovaries with radiation. It can be a malignancy in one or both ovaries, so it can be bilateral or it can present in only one of the organs. Ovarian cancer accounts for more deaths than any other gynecological malignancy because the ovaries are deep in the pelvis and the disease is often asymptomatic, meaning no visible signs of the disease until the advanced stage. Symptoms include enlargement of the abdomen caused by accumulated fluid, lower abdominal discomfort, lower back pain, irregular menstrual cycles, frequent urination, painful intercourse, and persistent vague digestive disturbance. The accumulation of abdominal fluid usually occurs in the later stage, and in most cases occur in women between the ages of 40 and 65. The risk factors include your age group, as well as a family history of breast or ovarian cancer. Factors that can reduce the risk include pregnancy, breastfeeding, and prolonged use of oral contraceptives, as well as tubal ligation, which is a form of birth control where the fallopian tubes are cut and then sealed shut. Why would a family member with ovarian or breast cancer increase the risk of the disease? And that's because of the genetic predisposition to this transformation. How do we diagnose it? Well, sometimes, but rarely, a mass is detected during a routine pelvic exam. A laparotomy is indicated once the mass is found to confirm the diagnosis. An abdominal or pelvic CT scan can be used to ID the degree of metastasis. Laparoscopic surgery is capable of viewing the ovaries because it's a surgery that utilizes a thin lighted tube put through an incision in the belly to look at the abdominal organs via a camera or to look at the female pelvic organs. Because the ovaries are so deep within the pelvic area, a pelvic exam is often unable to physically detect a cancerous mass. Treatments in the early stages include removal of the ovaries, fallopian tubes, and the uterus, and in the advanced stage, removal of the above organs in combination with chemotherapy and/or radiation therapy. The prognosis for these findings in the early stages is very good, 95% survival rate for 5 years. Most cancers have spread outside the ovaries by the time of diagnosis, and the survival rate, 5-year survival rate, drops down to 50%. If the cancer is found very early and the woman desires to still have children, only one fallopian tube can be removed. The other one can be left in place, and the woman will still be capable of ovulation and potentially pregnancy. Okay, fibrocystic disease is a common breast disorder of perimenopausal females between 30 and 55. The cysts are often linked to changing estrogen levels. To decrease the amount of breast pain, we can reduce caffeine and salt intake, we can use mild diuretics, and we can use mild analgesics a week before menstruation. Mastitis is a different type of condition. It's inflammation of the breast tissue that occurs during lactation and following birth. It's often caused by a strep or staph infection that invades the milk ducts and creates inflammation and blockage. The milk stagnates due to blockage and produces a dull pain in the breast. During lactation, what happens is that the female produces milk and stores it in the breast tissue. This is particularly painful if a woman is breastfeeding her child. Again, the extra added force due to suckling, the already inflamed breast tissue, and the pain becomes multiplied manyfold. Symptoms in breast post-delivery include sudden pain, redness, a heat sensation, It also tends to feel hot, doughy, and tough, and there's often discharge from the nipple. Other symptoms include lymph nodes near the armpit that can become enlarged. This is called lymphadenopathy, as well as fever and malaise. The treatment is a firm, supportive bra, heat applied to the painful area, progesterone creams, antibiotics, breast analgesics, and warm soaks. Breastfeeding need not cease if the patient improves. Warm soaks lessen the discomfort by removing inflammatory agents that accumulate in the tissue. Prognosis is generally quite good with early treatment. Okay, this is a look at breast cancer. It has the highest mortality in women younger than 35 when it presents in the form of an aggressive tumor, and women older than 75 where the immune system is less able to fight cancer and handle treatment side effects. The reason this presents a particular danger to women is because breast tissue is very near the, a large number of axillary lymph nodes and lymphatic capillaries, and so it's a very short trip from the breast tissue to the lymphatic system to the entire body. The result then is involvement of lymph nodes and rapid metastatic spread. So let's take a look at breast cancer.
I was terribly shocked to find out that I had breast cancer. In October, I went for my regular mammogram, and I found out that day that I had a spot on the mammogram from my regular doctor, and I was terribly shocked, and went in for a biopsy the next day and found out that I had cancer. And they could not feel it, but and as a matter of fact, it didn't show up in 3 out of the 4 mammograms that they took subsequently. But they saw it, and I had a biopsy and within 2 weeks, had a lumpectomy, and I waited for that to heal, and now I'm undergoing radiation for 6 weeks.
With regards to what surgery you wanted to have performed, in other words, doing a lumpectomy or doing a mastectomy, the choice really is yours, because the survival rate is identical for maintaining your breast with a lumpectomy or having your breast removed.
I go once a year for my mammograms, and this did not really show up before. I was in the practice of doing self-exams, but this one was very deep and very hard to feel, because the August, just before I had this mammogram, my own doctor couldn't find it. My greatest fear at the very first moment of hearing that I had cancer was, am I going to live? Am I going to die? But as I said before, the doctors were so positive about my recovery that I became that positive as well. My prognosis now, according to my oncologist, is in 20 years I have a 90% chance of being around.
Okay, an ectopic pregnancy occurs when the fertilized ovum implants and grows in a structure outside the uterus. Often, this is the fallopian tube. The ectopic pregnancies can develop when the fertilized ovum is unable to enter the uterus and is unable to implant and grow. The ovum is just another name for the egg. The blockage to the uterus can be due to pelvic adhesions or damaged fallopian tubes. These can often result from spontaneous or natural abortions, or artificially induced abortions, or disease processes that produce scar tissue that occludes the tubes. A tubal ligation or previous ectopic pregnancy increases the risk of future ectopic pregnancies. And this is just a peek at how an ectopic pregnancy might occur. Note the various locations where an ectopic pregnancy can take place, and if we look at each of these regions in the diagram, we can tell you what kind of ectopic pregnancy this would be. Okay, if you're looking here, this would be a tubal pregnancy here or here, This is normal implantation. Um, this is implantation in the outer adventitia into the middle region of the uterus, the myometrium, and this will result in, again, probably the need for surgical abortion. This is implantation onto the connective tissue that holds the ovaries and the fallopian tubes in place, and this is insertion onto the mesentery that anchors the intestines. And again, these are all infused with blood, so they're all going to provide nourishment to the developing baby. The problem is that we can't sustain the pregnancy outside the uterus, and the result is often the need for surgical abortion. Symptoms include sudden onset of severe lower abdominal pain, evidence of vaginal bleeding, no pain or pain on one side, a positive pregnancy test, and possible shock and death. Further treatments include laparoscopic surgery to terminate the pregnancy and remove the fetus and placenta, the replacement of lost blood, and methotrexate to terminate the ectopic pregnancy that has yet to rupture. And basically, what the methotrexate does is interfere with DNA replication and basically destroy the developing embryo. Efforts are usually made to preserve the ovary and the tube for future conception. The prognosis is usually good with prompt medical attention. If the fetus dies at an early stage, the fallopian tube isn't damaged, future fertility is possible. Okay, here's a look at spontaneous abortion or miscarriage. Causes of this particular condition could be maternal or metabolic disturbance, as well as travel, exercise, and intercourse that are not associated. Travel, exercise, and intercourse are not generally associated with miscarriage. It's classified as missed, as in no tissue passed, incomplete, some tissue passed, or complete, all tissue passed, depending on what happens during delivery. So let's take a look at miscarriage.
Miscarriages are very common in human reproduction. Good studies suggest that something on the order of 30 or 40% of conceptions end as either a very early miscarriage, perhaps not recognized by the patient, that is, a miscarriage or loss of the pregnancy prior to the expected next period, or as a clinically apparent miscarriage occurring after a missed menstrual period. So, the point being that this very common entity of pregnancy loss as early miscarriage or clinically apparent miscarriage will be experienced by many, many, many patients. Most experts believe that most miscarriages are due to chromosome abnormalities that occur at the time of conception. It's crystal clear from studies that have been done using largely clinically apparent miscarriage material that chromosome abnormalities are common in spontaneous miscarriage. If someone were to back off from the observation and say, well, why does that happen? I don't think we have a cosmic answer for that. The point, simply put, is that chromosome abnormalities are common in the occasional miscarriage that is also common in the reproductive population. A separate type of clinical presentation, though, is that of a patient with 2 or 3 miscarriages in a row. And those patients are anxious about their reproductive future. Usually the couple is quite distraught about the possibility that they won't be able to have children. So that kind of patient, that is the patient with 2 or 3 miscarriages in a row, will often, if not usually, seek medical advice regarding what are the possible causes and what might they do to improve their likelihood of successful pregnancy.
Okay, Morning sickness is the temporary nausea and vomiting that's experienced with the onset of pregnancy through the 12th to the 16th week. It generally occurs during the daytime. The nausea and vomiting often occur first thing when you get up in the morning. The cause is often elevated estrogen and HCG levels, which is a hormone that's produced in pregnancy by the placenta in order to help maintain now the corpus luteum in the ovary. And what that does is, as the corpus luteum persists, what it does is it produces hormones that maintain the endometrial lining and as a result provide nourishment for the full 9 months of the pregnancy. Women experience morning sickness often because of the buildup of HCG or one of its isoforms, as well as the buildup of estrogen or estradiol. Why does it usually subside at the end of the first trimester? And this is often due to changes in hormone levels at that time. The treatments include eating small amounts of food and simple hydration, as well as rest, the use of ginger in the diet, wristbands, and vitamins B6 and B1. The wristbands are a type of acupressure aimed at reducing nausea. Various drugs can be used if simple measures fail. The benefit of eating smaller meals is to reduce GI activity, and this reduces nausea. The condition usually subsides on its own by the second trimester. Okay, hyperemesis gravidarum is severe nausea and excessive vomiting that cause starvation during pregnancy. The severity of the episodes can cause weight loss, dehydration, and an imbalance in fluid and electrolytes. It's also believed to be caused by elevated hormone levels similar to those seen in morning sickness. The treatments include hospitalization in severe cases, IV fluids and electrolyte replacement, and IV antiemetics. The condition can be treated in a hospital, but is more often treated by home nursing services. Severe vomiting can cause complications, including rupture and bleeding of the liver and the retina of the eye. The condition usually subsides into the second trimester. Toxemia usually appears during the third trimester. The symptoms include hypertension, sudden weight gain, proteinuria, that's protein in the urine, and edema in the face, hands, and in the feet. Toxemia is the frequent monitoring of blood pressure, weight, and urine proteins to avoid a buildup of toxic components in the blood. If we have compromised kidney function, compromised liver function, or those organs are simply unable to keep up with the toxins that can accumulate during pregnancy, the result is going to be disturbance of homeostasis on the part of both the mother and the child. Okay, abrupto placentae is a medical emergency for both the mother and the fetus. Let's take a listen. Okay, prostatitis is an inflammation of the prostate gland and is more common in men over 50. Prostatitis can be caused by the same bacteria that's responsible for gonorrhea. So here's a little bit about prostatitis.
Hello, I'm Dr. Naeem Rahman, and I would like to discuss prostatitis, a term used to describe inflammatory conditions of the prostate gland. Prostatitis can affect men of any age group, although it is more common in younger men. It is estimated that 50% of men will experience this disorder during their lifetime. There are many classifications for prostatitis. Acute bacterial prostatitis is an inflammation of the prostate gland caused by bacteria. An infected prostate can cause painful urination and ejaculation, urinary frequency and urgency, pain in the penis, testicles, and the area below the scrotum and rectum. Usually a prolonged 4-week course of oral antibiotics is sufficient for treatment. Rarely, hospital admission with IV antibiotics is required. Chronic prostatitis is recurrent inflammation of the prostate. Symptoms are less severe, but the treatment can be challenging and variable. Oftentimes, antibiotics will not resolve symptoms, and treatment rests with analgesics, warm baths, and behavioral modification. Diagnosis of prostatitis is achieved by assessing for symptoms, digital rectal examination with a prostate massage, and a urine culture. I invite you to explore our website and see some of the treatment options we have, and better yet, make an appointment to discuss your treatment options in person.
Okay, BGH is treated by waiting, controlling fluid intake prior to bedtime, avoiding medications that cause urinary retention, such as decongestants, and also drug therapy to relax tight muscles inside the prostate or to shrink the enlarged prostate. Surgery may be performed to remove urinary tract obstructions. The prognosis is generally good with intervention. A lack of intervention can allow the infection to reach the kidneys, which can cause cystitis, dilation of the ureter, and other complications. The best means of prevention is a regular, complete prostate exam in order to detect any enlargements. Prostate cancer is a malignancy of the prostate gland. It occurs most often in men over 45. It is hereditary. The presence of certain genes predispose someone to prostate cancer. There's also a lifestyle component. Diets high in animal fat and low in vegetable and selenium can put you in a higher risk group for prostate cancer. Ethnicity also plays a factor. It's more common in African Americans. This type of cancer grows very slowly and is often diagnosed and treated before the condition becomes terminal. About 3% of men with prostate cancer die as a result of their condition. It is the third leading cause of cancer deaths in men. Okay, what you're looking at is one of the methods to deal with prostatitis or prostate cancer. This is a transurethral resection of the prostate. This is one of the ways that we core out the prostatic urethra in order to allow for urine flow to return. Malignancy of the prostate gland presents in individuals, male individuals over the age of 45. There is also a hereditary component and a lifestyle component. A diet high in animal fat, low in vegetables and selenium can contribute to increased risk for prostate cancer. It's also more common in certain ethnic groups, such as African Americans. It grows very slowly and therefore is often diagnosed and treated before the condition becomes terminal. About 3% of men with prostate cancer die of the condition, and it's the third leading cause of cancer deaths in men. The symptoms include weak or interrupted urine flow and frequent urination, known as polyuria, difficulty starting or stopping urination, urinary retention, hematuria, blood in the urine, and erectile dysfunction, or ED. This cancer is often without symptoms at diagnosis, and when the symptoms are present, many are associated with urinary obstruction. Urine flow can be obstructed in prostate cancer due to blockage of the prostatic urethra as the gland enlarges. We diagnose it with a digital rectal exam and a blood test to determine the level of prostate-specific antigen in the blood. This is the PSA test. And we can also engage in biopsy if the PSA level is above 10 nanograms per milliliter. Nodules or irregularities on rectal exam can also suggest prostate cancer. High concentration of PSA also suggests cancer, although biopsy is required to make the diagnosis conclusively. Malignant prostate tissue generates more PSA than normal, and as a result, this can be an important marker for diagnosing the condition. The treatment depends on several factors: the PSA level, the age, the stage of the disease, and the physical condition of the patient. The reason that the physical condition is a consideration is that the side effects of aggressive treatment may be worse than the disease, and as a result you may want to forego treatment of the condition. What are the risks of surgery for the older male? Well, men in their 60s who had surgery didn't live significantly longer than those whose cancers were merely monitored. And so in this case, the benefits of this particular treatment for particular age groups are somewhat inconclusive. Other potential treatment options include radical resection of the prostate as well as hormone and radiation therapy. There's often no intervention for men 70 or older who have other coexisting illnesses. Radical prostatectomy carries the risk of ED and impotence as well as urinary incontinence. Metastatic refers to the fact that the cancer has the ability to spread to other tissues, generally via traveling in the circulatory or the lymphatic system. We can prevent this with annual screening of men all age 50 or older. This consists of a digital rectal exam and a serum PSA. If either test is positive, transurethral ultrasound biopsy is performed to establish the diagnosis. There's a risk of a false positive and negative results with the PSA test. An easy way to remember the difference between a false positive and a false negative: false results are the opposite of the actual results. So a false negative may be an individual who has a disease but does not generate a positive test, whereas a false positive is an individual who does not have the disease but generates a positive reaction on the test. Okay, epididymitis is a painful condition affecting the epididymis. This is the area in the male urogenital system where the sperm become capable of using their flagella. The sperm naturally moves from the epididymis to the vas deferens, which is a single duct, before it's excreted from the body. So here's a look at epididymitis.
Sometimes a little dullness down there, and the doctor says, maybe you have to think of epididymitis or something. What's that?
Epididymitis is the inflammation and the infection of the epididymis.
Which is that all about?
The epididymis is the area of the testicle that is attached to the testicle that collects the sperm. And it has a head and a tail and a body. It's like a C, letter C, that goes over the testicle. And you have the head on the top, the tail on the bottom, and then the vas deferens that connects to it, and it goes over to directly to the seminal vesicles and goes to the ejaculatory ducts on the prostate. That's what collects the sperm. Now what happens when you have an infection in the prostate? The infection may travel backwards into the testicle, and the first thing that gets inflamed is going to be the epididymis. It may stay like that, or it may develop into an orchitis.
Is it an emergency?
No.
But if it's pain in the testicle, that's an emergency.
But pain in the testicle, right?
Probably not.
Right, and usually the epididymitis doesn't start all of a sudden. It's usually an insidious type of thing. It's different than a torsion. A torsion is a sudden onset of pain, and sometimes it's associated with nausea and vomiting. Excruciating pain. You can't put your legs together. It's very difficult to keep you asleep or whatever. And it's an acute emergency. The epididymitis, usually it's not. And the epididymitis, when you check the urine, you usually have pus. With the other one, usually you don't.
Okay, orchitis is an inflammation of the scrotum. The testes are housed in the scrotum. It produces sperm and testosterone. That's the main job for the testes. So let's take a listen to orchitis.
I'm Dr. Bob Lahita, the Chairman of Medicine at Newark Beth Israel Medical Center and Professor of Medicine at the University of Medicine and Dentistry of New Jersey. This segment is entitled, What is Orchitis? Well, orchitis is inflammation of the scrotum of the testicles. There are many causes of orchitis. The most serious ones are infectious. The mumps virus causes an infection of the scrotum which causes severe testicular pain and is often a cause of infertility if the orchitis is severe. There are other less common conditions such as cancer of the testicle, which is usually painless but can involve orchitis, something called torsion of the scrotum, which is twisting of the vessels and the epididymis within the scrotum. The epididymis are a series of tubules where the sperm is made in a testicle. That can cause severe inflammation and severe pain. The treatment of the infectious forms of orchitis are antibiotics. For more information about orchitis, go to about.com.
Okay. A testicular tumor commonly affects young males between 20 and 35. It's the most common type of cancer in this particular age group. The symptoms are painless masses out in the testicle. Treatment is orchiectomy, chemotherapy, or radiation. In cryptorchidism, what we have is an undescended testicle. Common causes include premature birth. The treatment is generally surgical movement of the testes into the scrotum. The reason for the testes being in the scrotum is that the temperature outside the body is optimal for sperm production, and so this reduction in temperature maximizes the number of gametes that the gonad is capable of making. Normally, the testes is guided into the scrotum through the attachment of a tendon called the gubernaculum to the inferior aspect of the testes that guides it through the inguinal canal and into the scrotum. As a result, men have two openings in the lower abdominal pelvic wall called the inguinal canal through which the testes descend. This represents a potential danger if you lift a heavy object. If you're a male and you lift a heavy object improperly, you can actually force abdominal pelvic contents into the testicle, and this is called an inguinal hernia. Very often this has to be surgically treated. Generally, the abdominal contents are pushed back into the abdominal cavity, and then mesh is sewn over the opening, and then it is stitched shut, and then you're educated on how to properly lift a heavy object, which is to bend the knees and keep the back straight. Okay, 1 in 5 adults carries the genital HSV-2 infection. It's usually transmitted by sexual contact. So let's take a listen to genital herpes.
Genital herpes is infection anywhere really in the genital or anal area by herpes simplex virus. There are two types of herpes simplex virus, type 1 and type 2. Type 1 is the commonest virus for affecting the face, orofacial herpes, cold sores as they're commonly told. HSV type 2 rarely affects the face, occasionally can, or the eye or the hand. Even if you've only had one sexual partner, you can acquire genital herpes from them, even if they've only had one sexual partner, because they could give you herpes simplex virus type 1 infection through oral sex. So even two people meeting who've never had any other sexual partner could end up with one of them having genital herpes due to herpes simplex virus type 1. So it's not a disease which should be thought of as being something of people who've had many sexual partners and explored a lot of different areas of sexuality. No, not so.
The virus leaves the skin cell and travels up nerve pathways until it reaches the ganglia. It can remain there in an inactive or latent state until it is triggered. When triggered, commonly by stress, menstruation, or fever, the virus replicates and travels back along the nerve to the skin surface. There it can cause blisters or other symptoms, and the virus is released during the outbreak. Sometimes, even without genital herpes symptoms, the virus can be released to infect a sexual partner. 3 oral antiviral medicines are recommended for the treatment of genital herpes. They are acyclovir, famciclovir, and valacyclovir.
The treatments available are very good, and I think that for many people just knowing what's caused their problems is very empowering. The treatments for people who present with symptoms and signs of either primary, first episode, or recurrent herpes are good. We can shorten the time to healing of all the lesions and make people feel better quicker. But for many people, the real issue is about preventing recurrences. And either they have to hold on to a box of pills and start taking them as soon as they get the warning signs that there's a recurrence due, and that can, in some cases, abort the episode and stop the lesions, the spots on the skin, coming out, and that can work for some people.
Okay, let's take a listen to gonorrhea.
Gonorrhea is one of the most common and widespread of sexually transmitted diseases. It is caused by the gonococcus bacterium and is transmitted through sexual contact and during childbirth. Gonococci cause inflammation of mucous membranes of the genital and urinary systems in males and females. If untreated, a chronic condition develops, and the infection spreads from the initial site of infection and causes fibrous scarring that can lead to sterility or ectopic pregnancies. Blood-borne gonococci can cause arthritis and life-threatening systemic infections such as meningitis and endocarditis. In the United States, approximately 75% of all reported cases of gonorrhea are found in people aged 15 to 29 years. The gonococcus bacterium are carried in semen and vaginal fluids and cause a discharge. Symptoms usually appear within 2 to 10 days after sexual contact with an infected partner. For women, the early symptoms of gonorrhea often are mild. A small number of people may be infected for several months without showing symptoms. When women have symptoms, the first ones may include bleeding associated with vaginal intercourse, painful or burning sensations when urinating, yellow or bloody vaginal discharge. More advanced symptoms, which may indicate development of PID, include cramps, bleeding between menstrual periods, vomiting, or fever. Men have symptoms more often than women, including white, yellow, or green pus from the penis with pain, burning sensation during urination that may be severe, swollen testicles. Symptoms of rectal infection include discharge, anal itching, and occasional painful bowel movements with fresh blood in the feces. Symptoms typically appear 2 to 5 days after infection, but could appear as long as 30 days after. Although penicillin can control gonorrhea, resistant gonococci have evolved.
Okay, let's take a listen to syphilis.
Over 30,000 cases of syphilis are reported in the United States annually, 2/3 of them amongst homosexual men.
Syphilis is a sexually transmitted disease caused by a bacteria known as Treponema pallidum. Syphilis is curable, but if allowed to progress without treatment, it can result in serious illness or death. Syphilis has been around for centuries and has infected some of history's most famous individuals. 18th century composer Franz Schubert, England's King Henry VIII, and 1920s gangster Al Capone all had deadly cases of syphilis. Today, the bacterium spreads the same way it always has, through direct contact with a syphilis sore, which are usually located on the genitals. For this reason, syphilis is usually passed sexually, although a pregnant woman infected with syphilis may also pass it to her baby. If a person contracts syphilis, it can go through 4 stages, particularly if left untreated. The first, or primary stage, is marked by the appearance of a painless sore or chancre, about 20 days after infection. Within a week or 2, the chancre usually heals on its own, but because a syphilis lesion increases the risk that a person can contract HIV by 5 times, abstaining from sex at this point is vital. After the chancre heals, the secondary stage of syphilis begins. A painless red or brown rash may appear on the body, especially on the palms of the hands and bottoms of the feet. The secondary stage is also characterized by flu-like symptoms, including fever, fatigue, and aching muscles. Because these symptoms are often indistinguishable from other diseases, syphilis is known as the great imitator. These imitation symptoms will usually resolve themselves without treatment within a few weeks. The third, or latent stage of syphilis, begins when secondary symptoms abate. At this point, there are generally no outward signs of syphilis, but the bacterium continues to thrive internally. If syphilis is not treated, complications of the disease can result in a 4th stage called tertiary or late syphilis. This can spread to other organs, resulting in neurological problems like a stroke, paralysis, deafness, or dementia. Cardiovascular difficulties like inflammation of the heart's major artery, the aorta, may also follow from untreated syphilis. Eventually, these conditions can lead to death. The good news is that penicillin has been found to be a safe, effective treatment for this disease. A muscular injection of penicillin, sometimes with booster shots, is all that is needed to kill the bacterium that leads to syphilis. Your doctor will follow up with blood tests to be sure that the medication is working. Pregnant women will be tested more frequently to ensure a return to health, as syphilis can cause death in newborns. Talk to your doctor about getting a blood test to check for this disease.
If you thought that clip was interesting, check out all of our videos, only at sexhealthguru.com.
Okay, here you can see an example of a chancre on the head of the penis. This is one of the early signs of a syphilis infection. This is indicative of the first stage before the spirochete begins to spread throughout the entire body. Chlamydia is one of the most frequently reported infectious diseases in the U.S. It's more common than gonorrhea, and it's the leading cause of PID and sterility in women. It's sometimes called a silent STD because it often is asymptomatic. The best way to avoid spreading an STD like chlamydia is to report cases to the Public Health Department. The CDC recommends annual chlamydia screening for sexually active women under 26 and for older women with multiple partners. Urine tests for chlamydia in men can help reduce the transmission of the disease to women. When symptoms are present, they're evidenced in both males and females, and they include, in females, thick vaginal discharge and a burning sensation, itching, abdominal pain, as well as pain during intercourse, and the clinical term for this is dyspareunia. If the symptoms are present, they usually begin 1 or 2 weeks after exposure and are likely to be mild. In male, we see discharge from the penis with a burning sensation and itching, as well as a burning sensation when urinating, and also swelling of the scrotum. 75% of males will show symptoms 1 to 2 weeks after exposure. The burning sensation when urinating is termed urethritis, which is an inflammation of the urethra that's caused by the infection. The treatment is antibiotic therapy given to both partners, initially a single injection followed by oral administration, and the patients are encouraged to abstain from intercourse until both partners are cured of the disease. It can be cured with a complete course of antibiotics. It's important to abstain from intercourse to avoid transmission of resistant strains back and forth between partners. Personal hygiene is also recommended to patients to avoid spreading infection in the eyes. Trichomoniasis is an infection of the lower genital urinary tract and affects about 15% of sexually active people. Most infected men and women are without symptoms, so they're asymptomatic. This lack of symptoms in most cases contributes to the spread of the disease, and it also delays its treatment. The symptoms when present in males and females include difficult or painful urination, itching, and in women a profuse greenish-yellow discharge from the vagina. This may eventually subside, but the infection will remain. The usual reason a woman seeks medical care is because of the irritating discharge. The diagnosis is discharge from either the male or female, typically studied for the microorganism that's responsible. Urinalysis can also be performed, and the cervix can be examined for the presence of small hemorrhages with a strawberry-like appearance. What prevents individuals who may suspect they have an STD from getting treatment in a timely manner is generally this asymptomatic incubation period. Recommendations for an individual who thinks they have an STD is to submit themselves for screening, and if there's a positive result, report the findings to the local public health department. Treatment includes anti-infective drugs that are given orally or in some cases vaginally, and a follow-up exam to ensure that the infection has been eliminated. The prognosis is good if both partners receive the prescribed treatment. If only one partner receives the treatment, the reinfection is likely to reoccur. Genital warts are an infection that causes raised cauliflower-like growths in or near the vagina or rectum along the penis. The warts are caused by the human papillomavirus and is usually transmitted through sexual contact. Warts are usually painless, but they're very contagious. They appear several weeks to months after direct sexual contact with an infected person. Genital warts are also associated with certain forms of cancer. Symptoms include possible itching or burning, discomfort that varies by the size, number, and location of the warts, and there's an added risk factor in that women with HPV infection are at greater risk for cervical cancer. The virus has an incubation period of between 1 to 6 months, and this long period adds to the increased risk of passing the infection to others or contracting the disease yourself. HPV infection in women puts them at higher risk for cervical cancer because studies show that women with genital HPV are at greater risk for cancer. Because the warts are spread more rapidly during pregnancy, a cesarean may be necessary. If the warts are present in the birth canal, this can occlude the passage of the infant through it. Co-infection with HIV has been shown to raise the risk of cervical cancer from HPV. Often the reason that these pathogens are associated with cancer is because they rearrange genetic material and as a result can potentially affect genes that control the rate of cell division in normal tissue. The treatment is topical drug therapy, and there is also surgical procedures such as cryosurgery, which is the freezing and removing of the affected tissue, or electrodesiccation, which is removing the warts using lasers, basically to vaporize them. Some genital warts disappear without any treatment. Although both drugs and surgery can remove the warts, the recurrence is very common in individuals who are susceptible. Pregnancy promotes the growth and spread of the lesions. The reason that pregnancy promotes the growth and spread of the lesions is that hormones or changes in the environment, as well as changes to the immune system, can allow the virus to spread. Normally, this would keep the virus in check, but with a decreased ability to affect normal tissue to warn it that viruses are in the area, things such as interferon may not be effective in preventing the spread. Dyspareunia refers to a recurrent, painful, or difficult sexual intercourse. It can occur in men and women, but is more common in women. The degree of discomfort and the reason for the problem varies from individual to individual. Physical causes in women include an intact hymen, insufficient lubrication, presence of an STD, use of a spermicide, endometriosis, PID, or the presence of cysts or tumors in the pelvic region. The hymen is a membrane that covers the vaginal opening. It can be ruptured during intercourse or during certain activities, such as horseback riding or playing sports. An intact hymen can cause pain during intercourse because the tissue can tear. A spermicide can cause discomfort as a result of an allergic reaction to components in the spermicide. There are also psychological causes. There's past trauma, sexual abuse, and fear of pregnancy, as well as other fears associated with sexual activity. Also, anxiety can play a role. Past sexual abuse can create psychological pain for women during intercourse. Anxiety alone can be sufficient to cause vaginismus. What intervention would you suggest if this were the case? Primarily psychological counseling. Causes in men include a bowed erection or an abnormal erection, a tight foreskin, inflammation of the prostate, or anxiety or guilt associated with intercourse. The reason that this guilt may be responsible for pain during intercourse is psychosexual dysfunction. Why might a male feel anxious or guilty about during intercourse? It could be anxious about the size or the shape of his erection, the lesions that are present on the organ itself, or the presence of the tight foreskin, which could, presage possible painful reaction during intercourse. Treatment is determined by the cause, but it can include the use of lubricants during intercourse, stretching of the vaginal opening, treating existing infections, and addressing psychosexual issues in counseling, or corrective surgery if necessary. Surgery may be needed for the small vaginal opening, or for fixing the painful erection, or for dealing with an overly tight foreskin. Frigidity is a lack of sexual desire or response in a woman. The patient may report an inability to experience arousal, excitement, or achieve an orgasm. It's considered dysfunction if the woman is dissatisfied or frustrated with the sexual experience. The way to distinguish frigidity from an unpleasant sexual experience is the pattern of behavior. Causes can include medication, chronic fatigue, stress, depression, or trauma such as rape or sexual abuse. Underlying medical conditions rarely cause nerve damage that results in frigidity. Stress can contribute as a result of a psychological block to orgasm. The treatment is training to enhance sensation and focus during intercourse, psychological counseling, and drug therapy, such as the use of testosterone cream to increase libido, particularly in women. Treatment may be as simple as training the patient to be more attuned and focused in their engagement with the sexual experience. Libido is defined as sexual desire and is controlled by both psychological and hormonal factors. Other issues that psychological counseling might deal with in this case are inhibited female orgasm that stems from psychological obstacles such as a troubled relationship between partners. In this case, a behaviorist approach of counseling for both partners can bring a positive result in fulfillment. Drug therapy can be used for loss of sexual interest and involves the use of testosterone cream, which can boost libido. Okay, let's take a listen to premature ejaculation.
Premature ejaculation is the number one sexual dysfunction in men. If PE is an ongoing problem, it creates discourse in a marriage and it creates discourse in a relationship. One of the primary difficulties that I found over 30 years of investigative work is that men and women have a great deal of difficulty communicating about premature ejaculation. So to work on premature ejaculation, we have to work on ways to slow the level and the time at which a man becomes sexually aroused. Now, it was discovered back in the 70s when a group of medicines called SSRIs, or serum serotonin reuptake inhibitors, were invented, And the prototype of that medicine was called Prozac. And a very good side effect for many people is that it delays the orgasmic reflex. Most people are not interested in taking an antidepressant to cure their premature ejaculation. However, up until a few years ago, that really was all that was available from a medicinal point of view. So it became an interest of mine to be able to A, understand the physiology of ejaculation, and B, to be able to come up with a natural supplement or a natural formulation that would help men. I think I've accomplished this with something called Detaine-X. Detaine-X is a natural supplement that, when combined in a dietary format, lead to higher levels of serotonin. So my approach to premature ejaculation has been one of inhibiting the reflex itself. Now, we brought Detaine-X to the market some years ago, and we've had a tremendous amount of success, large number of men and women who've written wonderful testimonials, and it's a very heartwarming thing for me to be able to offer this to you. It's my hope and my ambition to help you with what's one of the most difficult sexual dysfunctions known to man. Certainly what often happens is, because men and women are not great communicators when it comes to sexuality, it goes as an unspoken cancer to their relationship. The woman will sit back and think that the man has some control over his ability to have ejaculation, while the man is hurting deeply, thinking that he's not an adequate lover. And because the words go unspoken, it can lead to relationship deterioration. Women have told me that their husband doesn't try. Women have told me that their husband doesn't care about their sexuality. Nothing could be further from the truth. In my experience, men care a great deal about pleasing their woman or pleasing their wife. However, if they have premature ejaculation, it becomes an issue that's not solvable for them. Detaine-X is something that can improve that situation, and improve it quickly, and improve it with the knowledge that you're not going to suffer from side effects. To have someone get divorced over premature ejaculation is heartbreaking for the couple. It's heartbreaking for the people around them because they're not aware of the sexual dysfunction. It's very heartbreaking for me as a physician because I know that something could have been done. Now, talking about Detaine-X as a supplemental way to help you delay that ejaculatory reflex, we've also gone the next step and created tapes that include behavioral modification techniques. My tapes are graphic sexual tapes that are done professionally that teach you how to slow down the orgasmic response before it begins. Now remember, I said that ejaculation is a reflex. Once you achieve a certain level of sexual arousement, there's no way to stop ejaculation. However, there are behavioral modification techniques that can assist you when you use Detaine-X along with them. So I like to encourage people not only to take my product, the Detaine-X, for about 90 days, but I also like to encourage you to subscribe to our tape series and see the behavioral modification techniques that can assist you and your mate in making your sex life more fulfilling and to make your sex life more gratifying.
Okay, let's take a look at ED.
Erectile dysfunction, or ED, is the inability of a man to achieve or maintain an erection sufficient for his or her partner's sexual needs. Most men experience this at some point in their lives, usually by age 40. Incidence of the disorder generally increases with age. ED affects about 5% of men in their 40s and 15 to 25% of men by the age of 65. 50% of men over the age of 40 may experience transient ED and inadequate erection. Physical or psychological stimulation or arousal results in significant blood flow to the penis. The arteries in the penis supply blood to erectile tissue, which becomes engorged and expands as a result of the increased blood flow and pressure. This constricts the fibrous elastic sheaths, or tunicae, that cinch to prevent blood from leaving the penis during erection. Reduced blood flow to the penis and nerve damage are the most common physical causes of erectile dysfunction. Underlying conditions associated with erectile dysfunction include the following: vascular disease, diabetes, drugs, hormone disorders, neurologic conditions, pelvic trauma, surgery or radiation therapy, Peyronie's disease, venous leak, or psychological conditions.
Okay, infertility is the inability to conceive. With regular unprotected intercourse, about 90% of couples conceive within a year. Of those who are unable, 40% can be attributed to male factors, 40% to female factors, and 10% are unknown. The inability to conceive can originate in either sex. The percentages of male to female reasons for infertility are nearly identical. The causes in the male include an insufficient sperm count in the semen, inadequate motility of the sperm, the presence of an STD or any infection or block, or other physical conditions such as genetic disorders or injuries such as radiation exposure or hormonal imbalances that can result in sterility. Why do sperm need good motility for fertilization? Because of their long journey in the egg to the fallopian tube in order to accomplish their task. An STD can affect a couple's inability to conceive because of the presence of scar tissue or inflammation of the oviducts or the male duct system, which can impede the gametes' movement through it, and as a result keep them from meeting and affecting fertilization. In the female, causes include STDs or infection to the reproductive system, a failure to ovulate, endometriosis, blocked fallopian tubes, congenital structural or chromosomal disorders, scar tissue from infection, ectopic pregnancy or surgery, and psychological distress. Other causes include tumors, endometriosis, anti-sperm antibodies in vaginal secretions, and medications that compromise fertility. Other causes include basically physical manifestations such as blockages. Failure to ovulate would inhibit a woman's ability to conceive because the ovum has to be free of the follicle and reside outside the ovary in order for the conception to take place. If it's still inside the ovary, there's no way for the sperm to get to it. The one common cause that's present in both men and women is the presence of a sexually transmitted disease. The diagnosis in men includes a medical history with special attention to childhood diseases, a thorough physical exam, as well as semen analysis. In women, we have charting of the menstrual cycle, blood tests to assess hormone levels, visual exam of fallopian tubes and uterine cavity during radiography to determine tubal patency, basically if the fallopian tube is intact, as well as a laparoscopy that can be necessary to rule out endometriosis. A tubal pregnancy is where fertilization and implantation occur outside the oviduct. Endometriosis can thwart efforts at conception because irritation of inflammation and the formation of scar tissue in the duct system can impede the movement of the gametes. This prevents the eggs from getting out of the ovaries and being fertilized by the sperm. It can also prevent the sperm from getting through the vas deferens to the urethra. What are the treatments? Well, it varies based on the diagnosed problem, but it commonly includes infection control, surgery to remove the blockage, the use of fertility drugs, or, in extreme cases, artificial insemination. This is insemination, rather. This is a fertilization that takes place completely outside the urogenital system, generally in a test tube. There are different types of artificial insemination. There's intrauterine insemination, IUI, and in vitro fertilization, or IVF. Fertility drugs can also be used. What these tend to promote in the female is superovulation, basically the production of more than one egg at a time during ovulation. And this increases the odds that one of the gametes is going to engage in fertilization. Artificial insemination is the introduction of semen into the female reproductive tract independently of intercourse. About half of the couples that seek treatment for infertility are capable of achieving pregnancy, but it is not an inexpensive procedure. Okay, rape is sexual intercourse without consent of the individual. It may be against either sex. There's a high incidence. Date rape drugs are often used to facilitate this sort of activity, and it results in psychological trauma that is very difficult to recover from. Idatiform mole are intrauterine tumors that grow and growths that result from a genetic anomaly during fertilization. The patient experiences symptoms that mimic pregnancy, but no fetus develops. What does develop is a mass of clear grape-like vesicles. There may be a paternal genetic link. It's more common in Asian women, and here you can see an example of what this tissue looks like. These grape-like masses develop within the uterus in this condition, and they trigger physiological responses that are similar to pregnancy. Symptoms include abnormalities noted on ultrasound. The uterus increases in size disproportionately to gestational age. You also see nausea and vomiting and greatly elevated human chorionic gonadotrophin levels. An incomplete mole exists with a living fetus. In a complete mole, there is no fetus present. The treatment is surgical intervention, basically dilation and curettage, observation for hemorrhage. If the mole is found to be cancerous, the patient can receive chemotherapy. Most hydatiform moles are not cancerous. The prognosis is usually good with early treatment, and the condition occurs in about 1 in every 1,500 pregnancies. As we age, the reproductive system tends to reduce in efficiency, as do all body systems. In the male, reduced testosterone secretion, sperm count, and libido are evident. Men remain fertile into old age, but impotence may occur due to arteriosclerosis or hypertension. But in the female, there are abrupt, rapid changes due to menopause. The ovarian follicles are absent and gametogenesis stops, and the ovaries do not make sex steroids at the levels that they previously did. This results in vaginal dryness, genital atrophy, and reduced libido. There's also a high risk of osteoporosis and arteriosclerosis, again due to changes in hormone levels. Okay, that brings us to the end of this chapter. Be sure and review this material as it will be covered on the midterm. See everybody in class.